Hello and good evening, ladies and gentlemen. I welcome you to a session of medical diagnostics, which we all find it enigmatic in many, many ways. This evening, we have with us well-known doctors, Dr. Sanjay Arora and Dr. Kunal Sarkar, in conversation with Dr. Rupali Basu, Managing Director and CEO, Woodlands Hospital. Dr. Sanjay Arora is a Group Medical Director with Dr. Bilal Patlans and Non-Executive Chairman of Suburban Diagnostics Cytopathology. We shall know from him more about it. Dr. Arora is trained from Tata Hospital, John Hopkins Hospital, and Henry Ford Hospital, USA, and lives in Mumbai. Dr. Kunal Sarkar is Senior Vice Chairman Director and Head of Cardiac Surgery, Medical Super Speciality Hospital, Kolkata. Dr. Sarkar is passionate about coronary surgery and has the distinction of performing over 18,000 surgeries. On a lighter note, anyone having a heartbreak or a broken heart, not to worry, Dr. Sarkar can heal it. With progress of science and technology, material life is getting better and better now. So people have begun to have higher and higher requirements for life, and longevity has more yearnings. Therefore, labs are mushrooming and we are very, very dependent on them. A correct diagnosis is 3/4 the remedy. And I feel today our inquiring minds will help us know clearly about labs. Over to you, Rupali. Thank you.
Amongst your own committee, own organization, and been able to address with two of our stalwarts today. So I'll start with a quote which says that an accurate diagnosis is the first step to getting effective treatment. No one should suffer or die because of lack of diagnostic services or because of the right tests were not available. These were the words of WHO Director General Dr. Tedros in 2018. After that, we had so much in the whole world. So what I'll do is, you all know that diagnosis is actually a very complex process. For us doctors, we know how difficult it is. We have the same symptoms and signs which cater to many diseases which are very different. So it doesn't happen at one go. We have to have the differential diagnosis, then provisional diagnosis, and then we go to final diagnosis. It's a huge step. And lab tests, radiological tests, invasive procedurals, all kinds of processes actually help us, the treating doctor, to come to the confirmation of the final diagnosis. So as common people, I think we all think that there might be overuse of diagnostic tests. Sometimes we think that they are not to be used, or what is the correct combination? We have lots of questions in our mind. So, and we are absolutely true to being, from our side. And I think today what we will do is we'll try to, work on those questions which are there in our mind. And I'll ask both the stalwarts to kind of help us in getting those questions answered. I have actually listed down a lot of questions from all of you and outside. So we'll keep on asking you, both of you, questions. Before going into the questions, I would like your, about interpreting diagnostics, or mystifying the diagnostic services. We would like initial thoughts by you, Dr. Sanjay Arora, and then by Kunalda.
Thank you. Thank you, Dr. Rupali. Thank you for the warm introduction. Thank you, Ms. Suchita, for giving us this opportunity. Thank you, Rashi. Is she here somewhere? Rashi?
She's here.
There she is. So Rashi, thank you for giving me the opportunity of being here from Mumbai. Rashi runs a very nice startup which works with medical establishments in optimizing utilization of data. And thank you, Dr. Monica, who heads our lab in Kolkata. Dr. Monica is the head of that lab. I think demystifying diagnostics, that's what was the opportunity that I could share with all of you. Pathologists, I was with the lab before I came here, and I was asking, how many people choose to do pathology voluntarily, in the sense that most doctors, not as skilled as Dr. Sarkar, who gets a chance to become a cardiac surgeon, prefer to do more clinical branches, and pathology is considered to be paraclinical or non-clinical. But 70% of medical outcome depends on diagnostics. And that 70% contribution comes at less than 10% of the overall cost to the patient. So if you're spending 100 rupees, diagnostics will account for less than 10 rupees, but will contribute more than 70% of the overall diagnosis. There is a lot of clinical skill, and Dr. Sarkar obviously is the expert in that, but very well supported by diagnostics. But today, diagnostics actually has moved not just only to diagnose, but also directs on treatment, on therapy. Also follows up if the treatment is working or not working. It also looks at, before diagnosis, screening, that who is at high risk, who is not at high risk. And the whole era is moving towards personalized medicine. Previously, you would, if a diabetic came to a diabetologist, you would give metformin, which is a very common medicine given to most diabetics. There's a significant number of patients who don't respond well to metformin. Today, there are tests which can tell the diabetologist, is this patient likely to respond well or not likely to respond? So you don't have to do a trial and error. So all this information is available upfront through personalized medicine, through molecular diagnostics, through genomic studies. So there's a lot that diagnostics has evolved over the last so many years. And I think, unfortunately for us, as you said, that COVID, we needed a pandemic to really showcase the true value of diagnostics, where testing was such an integral part of managing this whole pandemic of test, track, treat, vaccinate. So testing became such an important part. And diagnostics, I feel, and we are in the sun today here, so truly found its place under the sun. And I'm so grateful that all of you are here today, giving me this opportunity of being here. Dr. Sarkar?
Yeah, Kunal, so if you can take the mic. Thank you.
Thank you, Dr. Arora. You see, thank you, Rupali, Sucheta, everyone, because whenever somebody thinks of a boring cardiac surgeon in a panel discussion, I think first thing is that the wisdom of the selection committee is held in doubt. The other problem this afternoon is that I find myself, or myself and Sanjay, finds ourselves seriously at a disadvantage as far as the gender parity is concerned. And the other business personally is that I am really sort of almost out of my depth as far as the domain is concerned. And one of my very wise teachers once taught me that if you're ever in confusion, the best subject that you must recourse to is history, right? Because it's always happened in the past. It has no forbearance on the future, and you can go on babbling about it for time immemorial. Now look, the first, we'd say today that the dawn of modern medicine happened in the hands of a pretty lazy fellow, and his name was Hippocrates, of course. So Hippocrates, why was he lazy? He was a great thinker. All he was trying to do was he was trying to separate medicine from religion, from the hand of the priests. And Hippocrates, for a good part of 7 decades, he lived in the tiny island of Kos. He seldom ever traveled to Athens. And when, today you said the oath of Hippocrates, the foundation of medicine. So Hippocrates said 2 things. He said a lot of right things. You must work to the benefit of the patients, never harm anybody, etc., etc. So fortunately, Hippocrates said 2 things, which today I have contradicted a part of it, and Sanjay has contradicted the other part. First thing Hippocrates said, you must never ever test anybody's blood. Because that day and age, people were desperately scared that blood in the body exists in very small and finite quantities, and you must never drain out blood unless you have to, and so never ever think. So how did diagnostics start in the history of medicine? Diagnostics started with the testing of urine. Urine was the universal test that was done. And for some of you who haven't seen the movie, I refer you to one great movie called The Madness of King George, where King George III, if you think that the current batch of the British monarchy are acting a bit mad, especially with Prince Harry and his new wife, whatever she's called, but there were actually people who were certified mad in the British monarchy, and King George III was one of them. And his main physician, the physician's holy duty every morning was to taste his urine and the solid excrement he would put out every day, because that was the only kind of diagnostics we were depending on. And from that time onwards, it has been a long journey for medicine. If there is one person in the history of medicine whom we have to be grateful to for developing diagnostic blood tests, etc., it was the Canadian physician called Osler. Now that's a different story. And we have come down a long way from there, because diagnostics is really adding a lot of credibility, a lot of accuracy, and a lot of effectiveness to clinical medicine today. In summary, let us consider where the journey of India in medicine, because when we talk about healthcare delivery today, we think about hospitals, we think about pharmaceuticals, we think about diagnostics, we think about healthcare insurance. So these are the roughly 4 verticals in which healthcare industry is divided today. So you are all related to and very involved with chambers of commerce. So India's healthcare industry stands at about $300 billion in a $3 trillion economy, which roughly pegs it around 10%. And out of the $3 billion industry, hospitals eat up about or contribute about 70%. And diagnostics today are standing at somewhere around, I think, 10% to 12% of the entire pie, and doing very well and growing fast. But when we think about healthcare in India, you see, we have to think about the 2 extremes. In the society where in one hand, we are the world's 5th largest economy. In the other hand, we are 118 as far as per capita income is concerned. So the both realities of India exist. Today, for any Indian who are holding an Indian Aadhaar card today, the per capita spending, entire healthcare spending on any one of us, divided by the population of the country, any single year is 3,000 rupees. 3,000 rupees per head per year is India's entire healthcare expenditure. Obviously, it's not 3,000 rupees for you, but somebody from the back of beyond who is probably still constitutes 60% of India's population, it is that. So we have to address to 2 ends of the spectrum. And as we strive to do that, like in diagnostics, similarly in therapeutic medicine, Indian medicine has a very odd character. And that character is that we are the only developing country, the only per capita low GDP in the country, to where the rest of the world, from a higher GDP country, they come to a lower GDP country in search of medical tourism. It never happens for any other industry, any other vertical, anywhere. Today, even after having an IIT in every traffic light, when you want to buy a Rafale jet plane, you have to go begging and borrowing to France to buy an aircraft. But today you need a brain surgery, an advanced orthopedic surgery, a lung transplant, a heart transplant, you have it here in this country. Similarly, for both clinical and diagnostics, I think we've traveled fast. as we stand in the India of 2022, you see, one thing is very important. All of us, we think, we've done a great bit. We were trying to hide under our breath a statistic of shame. And that statistic was that 70% of India's healthcare expenditure was out of pocket, whether it was to get a hemoglobin checked, whether it was to get an appendix out, a gallbladder operated, or whatever. And that was punitive for 90% of the country. When you study the finance budget and the CAG report on healthcare, which came out in 2021, for the first time ever, in the history of a 74-year-old country, because of the government health schemes, both at the central and state level, which is causing the hospital sector a lot of pain, a lot of hardship. But we are living through the hardship because that 2021 is the first year when we have actually documented and presented in a credible way the total out-of-pocket healthcare expenditure decreasing. From 60%, it has now come down to 48, 49%. So, this advantage in diagnostic, in clinical medicines, etc., has to reach out to both ends of the spectrum, because unless we do so, our journey in medicine is only half fulfilled. And I'm not trying to advertise for any party, any government. Like you have Dr. Lal's Path Lab, like you have the chain of path labs throughout the country, there is another very interesting chain of labs which are coming up, and that is called the Ayushman Bharat clinics. Because we have a bit of a combative relationship between the state government and the central government in this state, we don't see as many as you would have seen, say, in Assam. There are 4 in this city. I have visited one of them because, I go out begging for patients in the districts and in the outbacks of the state very often. And in those clinics, they are combining a doctor sitting down, getting the diagnostics done, the common order test straight away, and there the people at the state's expense is getting both the diagnostic and the medical advice. So I think this represents a very interesting time with a lot of growth potential, with a lot of enthusiasm, but what is desperately important is that both ends of the spectrum needs to be addressed to for our healthcare journey to be fulfilling. Thank you.
Absolutely, Kunal. That's touching on the right, right chords, because in our country we continue to be inequitable in our distribution of healthcare needs for all citizens of India. But at the same time, he also mentioned that we provide the best in the world. So that's also, we have achieved there, but it is not available for everyone. And that is the journey that we have to, kind of accomplish. And Ayushman Bharat or, Shastro Shati or the kind of schemes which the state governments and the Indian government are bringing in are actually to help that every Indian gets that, the standardized quality care. I'll come back to I think interpreting diagnostics that's the, from the overall situation, come back to the questions. And I think the first question to you, Dr. Arora, is that we are, told that there has to be some tests to be done regularly. We are told that these are some set of tests you do every time, every day, kind of or some regular interval. So what are these tests, and how regularly do you think we have to do a regular check?
Well, actually, that's a very generic question, and the regularity of tests depends on multiple conditions. One is, of course, the age. At different stages of your age, as I said, screening, which picks up conditions at an early stage, and that's the importance of screening, is that you don't have to wait for symptoms to appear. You can actually pick up conditions at an early stage. So at different stages of your age, you do different sets of tests. So you would do a much smaller group of tests, say when you're 20 or 30, but as you grow older, the number of tests need to increase. And depending on the outcome of the results, we decide how frequently they should be repeated. Now, for example, the commonest condition in India probably is diabetes. Yeah. Now, let's take diabetes as an example. If somebody has raised blood glucose or blood sugar, the recommendation is that you repeat your blood sugar or blood glucose maybe every 2 to 3 months if it is out of control. Along with that, there is a test called HbA1c or glycosylated hemoglobin, which is something which you can do every 3 to 4 months.
Yeah.
So depending on the type of test, you also do a lipid profile, which is a cholesterol test. You could repeat that once every 6 months. Now, that's for a diabetic, but for somebody who's doing a routine health checkup where most of the parameters are normal, probably you need to repeat them every once a year. So it depends on the age, the medical condition, the outcome of the results, and of course the clinical interpretation. So the clinician will also add his or her value to it, how frequently they should be repeated. And there is pretty much, these 4 conditions will decide the frequency of how a test should be repeated. In Dr. Sarkar's case, for example, when you do cardiac surgery, you need to do a test, to keep your blood thin, which is prothrombin time.
Yeah.
Now, he will give medication, and you need to monitor the prothrombin time to make sure it is between a range of 2 and 3. As long as it stays between that, I guess you just need to repeat it every, say, 4 months, Dr. Sarkar? How much would you recommend a prothrombin time to be repeated?
2 to 3, we repeat it every 3 months.
Every 3 months.
Because if you want 3 months, you have to say 2 months.
So it's like when every one of us can actually have something in our minds that these are the tests which we should do at this point of time.
Absolutely. So I think we can share information on,
I was just coming into the health records or health files, or are we still at this stage, at this, 74 years after independence, are we giving enough importance to our own personal health files?
That's why I think Dr. Sarkar touched upon that why is it that we look at health the way we do today, that healthcare in India is reactive and not proactive. I think he spoke about the fact that India is one of those countries where health expenses are still out of pocket. And unfortunately, our own personal health features very low on a priority. You look at your business, your house, children's education, travel, entertainment, everything, and health only comes. We take our body for granted. Whereas the way I look at it is, if you want to take care of anything in life, you have to first take care of yourself. If you can take care of yourself, then you can take care of anything that is important. So investing in yourself will allow you to take care of everything else in life. So I think that life cycle has probably changed a lot during COVID, where people realize that, what the word comorbidity has become something which most people know the word. What does that mean? That
Absolutely.
you already have underlying medical conditions and you are predisposed to complications of COVID. I think so the awareness unfortunately happened because of a pandemic, but at least people are now aware that if they have an underlying medical condition, they are predisposed. So I think the whole opportunity here is how do you make people more proactive rather than being reactive.
Okay, but yeah.
You see, I think what Sanjay said is so true. You see, a lot of the things that we make them to be, in front of you as being something very systematic, something very new, etc. You see, nothing is very new in what we are doing today. When you discuss things like cholesterol, lipid profile, etc., say vis-a-vis heart problems, cardiovascular problems, this is a knowledge that we've had from 1969, 1968, right? So when was the first cure of diabetes discovered? This was in 1921, 1922. So all this is pretty much old wines in new bottles. We are at a unanimity. All of us know by seeing people, various demographic cross sections throughout the world, that this is where trouble happens, and this is a kind of checkup schedule most of us must go into. Now, in the world today, there are two extremes. Say, for example, today you were an average citizen somewhere in the United Kingdom. You suddenly suspect, or somebody suspects, you might have a touch of diabetes. From the time you think you have diabetes till the time you will get your blood sugar checked up is going to be at least 3 months. 2 to 3 months if you wanted a blood sugar check at the Queen's expense. And out over here, our problem is that you may have about 100 labs queuing around for you. Suddenly you utter the word, I want to have a blood test done. You may have a whole army of phlebotomists queued up outside your house, 6 o'clock in the morning, wanting to check a fasting blood sugar sample from you. So we are somewhere between the sublime and ridiculous at this day and age. But we must make advantage of the fact that we have good diagnostics, we have good ability. And what I wanted to add regarding tests, you see, is say labs like Dr. Lal's Path Lab, labs like ThyroCare, etc. I was a bit surprised that when I looked through the data, that they are probably what? They are probably at something like 10% of the market share. So it's like hospitals. Today you think of an Apollo, you think of an NH, you think of a Fortis, you think of whatever. All the big brands of healthcare added together is about 10% of healthcare. The entire 90% of diagnostics and 90% of healthcare belongs to the small sector, MSME, wherever.
Yeah. And there the question
Therein, I think, a lot of hand-holding is necessary because the quality...
Also the quality parameters.
The quality, the credibility of the tests and things, that is, where I would ask a question to you. That
exactly.
Cutting across these two sections, across, say, a chain like yours, which, people would have a test out of you with their eyes shut. But if I wanted a set of tests for somebody living in the districts, etc., do you think we have achieved that uniformity?
Uniformity, also reliability of the tests.
Sure. No, I think extremely valid point, Dr. Sarkar, that as you mentioned that there is the organized sector and the unorganized sector. I think that's what we are speaking about, that in healthcare overall, at least in diagnostics, 10 to 15% of the sector is organized, 80-85% is unorganized. And I think that's where the gap is. We don't have statistics on the number of labs that exist in our country, but roughly maybe 3 lakh is what the latest data says. Now put that into perspective, there are less than 10,000 pathologists in the country, but there are 3 lakh labs. There's a big gap between who is running the remaining labs. The second is, there is a voluntary accreditation which is available in our country, which is called NABL. All the organized labs, at least majority of them, go in for voluntary accreditation. So out of the 3 lakh laboratories, less than 3,000 are NABL accredited. So if you have 3,000, yes. So that's, 1%.
Just 1%,
yeah. So I think that's where the gap is. Now, how do you enable labs to become more vigilant? How do you create some sort of, quality criteria? So there is something called as the Clinical Establishment Act, which has been formulated by the Health Ministry and the Government of India, but many state governments have not yet implemented it. Now that actually lays down criteria, how a lab should be set up, what should be the criteria, how much space, what kind of people should be employed, what kind of training records should be there, etc., etc., etc. Now when we implement these things, I guess that's when the standards will come up. At this point of time, I have to agree, there is a gap between, the accredited and the non-accredited, the organized and the unorganized sector.
I think that's what actually talks about even for the hospitals, that many of the hospital services are not accredited, although there is voluntary quality accreditation available. And I, for whatever 20 years of heading hospitals, have always kept on talking about that, standardize your care and go for accreditation, because that's at least gives you that every process you are doing in a standardized manner, every clinical pathways, standard treatment guidelines. So those are the things which are still to be done for all hospitals and all laboratory services.
Another point, Sanjay, would be that you see across this vast expanse of the country, what Rahul Gandhi has taught us is how long India is actually. After a long time, we've got to realize that it is 4,936 kilometers, something of that description. But anyway, he's doing a great job of it. But the trouble is that when we venture today out into the tertiary branches, like today, we have taken on a very active program of heart and lung transplants. Now, I have 3-4 patients outside of the state Even if I want to do 2-3 transplants a month, when we try to do, I was just telling you that out of the state, somebody is listed with me from Sikkim. Now, how do I get all these fancy, antibodies, PRA, blah, blah, blah stuff done in Sikkim? How do I get the chap sitting in Agartala do it? So connectivity is a problem.
And I call
In India, we bring organs in aircrafts. The last heart we harvested was in Patna, and we had a heart sitting in an aircraft with a ticket. And when I showed that slide in USA, the surgeons fainted. They never ever realized that an organ can come in a passenger aircraft. So similarly, I think your challenge is also reaching out to the corners of the country, that how do we do that?
So, I can speak for our organization that as a diagnostic company, we have the opportunity of optimizing on logistics. And I think to a large extent, you would not only remain a testing company, but you also become a logistics company. And today, our organization has a very large network. We have...
Do you have a central lab? Or you would spread
That's what. Also, the role of a reference lab, there are questions from President that why is this test is not happening in
So
in
there is a hub
Calcutta.
and spoke model.
So,
So
Also the way to you are sending the samples, the quality of your cold chain and all
there
that.
there is a hub and spoke model. You have satellite labs, you have regional labs, you have reference labs, and this is decided by the testing capabilities of each lab or the requirement of testing, which is so you are as close to the patient for tests that need immediate results. So if somebody's got fever and you want to diagnose malaria, you need the result in quick time. So you do those tests as close to the patient as possible. But if you have, for example, a thyroid test, even if you get the result after 24 hours, that could be done at the satellite lab, which is, or a regional lab. But if you have, like you said, a cancer biopsy, it does not need to be given the same day. You can give it after a few days. So that can be centralized to a reference lab like we have in Kolkata. Tacrolimus, that was a question that you had asked. I'm surprised because our lab in Calcutta has been doing it for I don't know how many years now.
No, it's not
5
doing.
years?
Actually, it's not doing, Sanjay. What's happening is, it's not happening. What's happening is every time, even the reference labs, which is a big, big question. I think it is everybody's mind that, not all tests are done in one city. Say Calcutta, President asked that tacrolimus, it's a drug level for a cancer patient. So when you're measuring the drug level, you don't. There are many tests which we don't have in Calcutta, and all those samples go to Bombay, to the reference lab in Bombay. So there is a time gap. I know that for sure.
No. So
many things are not happening. Cytomegalovirus. I think Deep, are you there in the or not there? Yeah, Deep, can you? He's our pathologist. So Deep is a microbiologist actually by profession. What are the things that we don't have in Calcutta?
Deep, please do connect with Dr. Monica after
just
this
give
talk.
us a
And I can reassure you, not just you, but everybody here, that the Kolkata reference lab does practically everything that you need. But there will be that, 0.5% of the tests. So doing tests...
No, it's not only Dr. Lal's path lab. I'm talking about as a service for the entire region.
No, but if there is a test that you believe...
Some kind of a blueprint issue is there. When we don't
so I'll tell you this.
Look at the country as a whole.
If Kolkata came back and told us that these are the 5 tests which we believe
need
to be there in the city.
So it's not the Calcutta requirements from all healthcare organizations. It's not there. When we are not together to say that these are the 6 tests, maybe we have to be together.
No, Rupali, I think it's always evolved that way. You see, if I remember, memory serves me right, it looks like a long time back. Just prior to the first, when the lockdown was announced, India started off with 5 RT-PCR labs. 4, yeah.
We were one of them.
So India, the whole country had something like 4 RT-PCR labs, isn't it?
Yes.
That is where the journey started from.
Absolutely,
And we were shaking hands with the first lockdown. And God knows where we have ended. I think, that has really been...
No, absolutely. Dr. Lal Path Labs itself
Yeah.
had 25 locations across the country doing RT-PCR eventually.
Right now, yeah.
Absolutely.
No, that's what I'm saying. So it's emerging. So it's the situation is emerging, and it may not be absolutely the ideal for at this moment, but we have still issues
No,
of
but it's a-
tests going
No, but
to...
Rupali, one thing. I want both of your inputs from, look, when push comes to shove, when we are, when you are staring down the barrel of the gun, then even in a place like, say, Manipur, or a district town of Imphal, we've set up RT-PCR and all these structures over there. But right now, you go back to the same places in an elective level, and you say, like, can we get a blood culture? We operate twice a month in Imphal, in Manipur. Now, if somebody referred to us, I say, can I get a blood culture there before we do some surgery on some patient? They are very hesitant to do that. So isn't this a dichotomy? Because we have done it.
So I was just going to say that there is it's an evolution of
the structure.
It's an evolution of demand and supply, right? So if there is a demand, we have the capability of providing the supply. Let me put it that way. As I'm saying that if there is a list of tests that, Dr. Rupali, you believe are not present in Kolkata today, give us that list. We will work on it and come back to you on how we can make it available. So there is a capability of doing every test. It's about the demand and supply. It's about the workload. It's about evolution, as Dr. Sarkar said. Now, if in Imphal, I'll have to get back and check if we have a lab that can do blood culture there. But if there is a demand, I'm sure we have the capability of providing the supply.
So I think it's now 20 minutes to 5. I think we can, close our conversation here, and maybe we can open it up from all of you. Parul has a question. So can we have the mic to? Yeah, please.
Good evening, doctors. I have a different type of a question. Since you say that our healthcare we should be proactive in it, so there is a whole list of tests, just like you have mammography and maybe some other tests. So there's a whole list of tests that can be done to find out if we are prone for that cancer. Like you have prostate cancer, so you have a PSA test done, C125 for, the various tests.
Ovarian cancer.
So, yes. So it would be very helpful for us that if the simpler tests like that, I think there are some 10, 12 or 15 simple things like blood tests that can tell us if someone is heading towards or has some cancer cells in them. Can you give us,
absolutely.
enlighten us?
So, ma'am, I'll make sure that, the group out here gets those list of tests, age-wise, gender-wise, what are the recommendations, why these tests are recommended, which organs do these tests, are valuable for. I'll make sure that our team here, Dr. Monica is leading that team. I will make sure that, Ms. Sucheta will get it and we'll be able to circulate that entire list with you.
One problem where we all stand guilty today is that, you see, we are missing out on the general comprehensive advice that some years back used to be given by our proximate general practitioners. Today, many of us are a prey to this madness for super speciality at the drop of a hat. So that is a problem today. That is why, as you say so correctly, that there could have been an age-specific screening program. Because, look, in the last 10 years, the longevity of India has gone up by 8 years. It's not happened anywhere else in the world. Right. It's 74 years of our freedom today. So in 1947, an average Indian woman, the life expectancy was 32 years. The average male life expectancy before in 1947 was something like 44 years. And today we are 65 plus. If you happen to be a Japanese in Okinawa, there 5% of people live beyond 100 years of age. So this is so important a question, because as we get into this habit of living beyond 60 and maybe living beyond 70, etc., what we are seriously missing out on is comprehensive general practice kind of cover and advice. somebody give to me, I'm only focused on lipid profile. Somebody goes to a so-called diabetologist. The guy doesn't know the world outside sugar.
No, no, we'll make sure that gets corrected.
Yeah,
I mean,
so
we'll
I
make
think-
sure that age and gender-specific screening tests, Dr. Monica will prepare that and we'll share it with you.
Okay.
Definitely.
Thank you. Any other question from the audience? Romantic, can we have the, yeah.
I think you had a question about, you were concerned about getting samples from across the country and the viability of those samples. So, like I mentioned about the logistics not only takes care about movement of sample, but also takes care about the condition of the sample. So there is a cold chain that is maintained, and because you are accredited, you have to keep a record of the temperature in which the samples are transported.
That's what. So it happens with the 10% accredited organization. What happens to the rest 90%? That's the question.
It's
Most of them travel by local train.
Exactly.
And whatever be the God-given atmospheric weather and humidity conditions, that is where a lot of transport happens really. So anyway,
We still remain
something's,
fortunate.
something's
yeah.
better
Something's-
than nothing.
Yeah.
No, we can speak only about what we can control.
Yeah. Romanti, you have to. Genome.
Genome.
You want the meaning of genome?
The genome, ma'am, actually refers to, all of us have our, inside of our cells, we have our genetic characters. The genetic character that we have inherited from our parents. So all these genetic materials which exist in two forms, RNA, DNA, etc. So these are like you used to play with long ribbons. So that we don't have enough space inside the human cell. So space is very limited. So that is where all the genetic information, like the telegraphic code of yesteryears, the long telegraphic signals, they are all wound round in one long genetic sort of material. And if you start unwinding that ribbon, and if you start reading that genetic code, like, the human genome, every bit of gene we carry in ourselves, that was first decoded in about 1992, 1993. It took a long time for us to. So if you decode me and if you decode a monkey, there is only 1% difference in the human genome. So that 1% difference has made me a man, has made that a monkey. So everything is coded inside things. So genome refers to the entire body of genetic material inside.
It's our code.
It's like a code.
It's like our internal code.
And why do we need the code? Because that code is controlling our aging, our hormones, all the proteins and hormones and everything inside the body. So that is working on the signals generated by the genome.
And
So now there are tests available, as Ms.
I
Sucheta was
just want
asking,
to
that
add on that. The
you can do
genetic-
something called as whole genome sequencing,
Yeah,
which you
yeah.
can actually get every individual genetic code. Of course, you don't need to do that for every condition. There is something called a limited, where you do targeted. So most of the time, genome sequencing is done when you want to target diagnosis or therapy to know if you are predisposed to something, like she was talking about cancer. And if you get diagnosed with cancer, now you can actually do to know which medicine will work best against that person. So everybody has a genetic code. And I think it's taken time, but today the genetic code is accessible to us. Each one of us can get our genetic sequencing done. We know our genetic code. We are born with a specific type of code, but as we age, as we grow, there is something called as epigenetics. The environment, our behavior, our habits, they also modify our genetic code. So why do some people get cancer and some don't get cancer? It's the epigenetics. It's the influence of our environment and our behaviors on our baseline genetic code, which finally expresses differently in different people.
The only other point which I
Sorry?
would like to add on here, what is that word called? There is something now. Say, for example, when I do a bacteria happening, a tuberculosis happening with me, so I will grow the bacteria in the lab, and then that takes time. So now there is the test kits
Sequencing.
are genetic coded, so it becomes much more easier and faster and standardized care.
Look,
So that
what
way-
we are actually heading for is trying to diagnose the manufacturing defects at birth. that God is as error prone as any one of us are.
Yes.
So, we subscribe to all these simplifications that if you have diabetes, cholesterol, high pressure, smoking, blah, 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 7 risk factors, then you'll get heart disease. Fine, brilliant. This formula only applies to 70% of people. There are a good 30%. This afternoon I've seen somebody where 7 people in the family have died under the age of 50 who had none of the single risk factors. So which means there is something crazy happening in their genetic structure. The trouble is we are not yet clever enough to pick it up. So like once you leave the shopping market, you have these barcode screening. So some clever chap somewhere is going to do a barcode screening of our entire genome. But you look, in order to do that, we ourselves have to identify that what are the genetic sequencing which is predicting this set of diseases. We don't know that yet. So that is where the knowledge deficit lies. The time we get to know, by the time somebody is 5 years of age, that you are predisposed to be diabetic, at that stage you can prevent diabetes. Today we are treating diabetes, we cannot prevent diabetes. So there is a profound difference between that.
But eventually, and just to continue what Dr. Sarkar is saying, there is something called as genetic engineering, where you will be able to engineer the genes, where you can actually then, if you know you're predisposed to something, you do gene engineering to actually modify the gene so that you can actually prevent this from happening in the future.
And the future is very, very interesting in that way. Yeah.
Good evening,
Next
everyone.
question. Yes.
My question is, at times, lab report differs from one lab to another. So why it's like that?
Of the same test you are talking
Yeah,
about.
same test. I have experienced myself on me. That's why I'm asking.
Same time?
2-3 days.
2-3 days.
So that's a very common and a very nice question. I think it's very commonly asked to most of us. So there are some things which are called as physiological variations. So if I did my test at the same lab on 2 different occasions, my body will not give exactly the same result at the same time. So if I did my hemoglobin at my own lab in the morning and I did it in the afternoon, there is a physiological internal variation which itself will differentiate from one time to the other. That is one. So we must be aware that there are certain tests which give rise to physiological variation. I'll give you a common example. In your lipid profile, you have cholesterol and you have triglycerides.
Yeah.
Now, triglycerides vary significantly due to your diet that you had the previous 3 days. So typically when people do a lipid profile, they will go on a very strict diet for at least 3 days before the test so that the triglyceride levels are under control. But then I tell those people that you're fooling yourself. If you regularly like to have alcohol, if you regularly eat non-veg, if you regularly do this, don't stop doing that just to do the test. Whatever is your regular lifestyle, continue doing the test. So what will happen is if I stop doing that, my triglycerides will come down, but one fine day I'll do a lipid profile where I did not. And I'll suddenly see that my triglyceride was much higher. And then we'll question the lab, but actually it's just, we know that triglycerides can vary. If today it is 200, tomorrow it could be 300 or it could be 100. That's the variation that's possible. But cholesterol does not vary so much because of diet. So there is a physiological variation. The second is the method or the kit or the instrument on which the test is done. Now, because of accreditation, because of international affiliations, we have to put down that on the report that we are doing it on this machine, by this method, by this process. So there is transparency, but not everybody. So every kit, every reagent, every instrument will have its own reference range, which will be different from. But if you follow a standardized protocol, which is as per, I said, NABL, then that makes all labs standardized. So if you were to repeat a test within the same boundaries of your own physiological variation, but from one NABL lab to another NABL lab, you will find that the variation is acceptable.
Thanks.
Any other question? Another 5 minutes.
You just wait for the time till all your profile will come on your mobile, Yeah. No, honestly, that's not too far away at all.
It's already there. It's already there.
It's not too far away.
Yeah. So I think there was a question on autoimmunity. So recently, about 7 months ago, we launched a center of excellence on autoimmune disorders. About 7 to 8% of the normal population suffers from autoimmune disorders. Autoimmunity means normally when you get a foreign body, your body reacts by creating antibodies against something which is foreign to the body. Autoimmunity means the body is producing antibodies against its own tissue. So there is something called as Hashimoto's thyroiditis, which is very common in women. You get variation in your thyroid results. That's an autoimmune condition. So we have actually launched a center of excellence focusing only on autoimmune disorders, explaining to clinicians, explaining to patients. Again, we will share that details with you on what are the various tests that are part of the autoimmunity and how they can be diagnosed very easily.
Any questions? Otherwise, we'll close now the session. No, I have not yet covered all the questions. I think, these days they say this question of, everybody is asked to do an LFT, a lung function test. No, they're talking about lungs. This is what the lung functions are being.
No, LFT commonly means liver function.
They're
Lung
saying
function
that
is
the doctors
PFT, what they call pulmonary function
No.
test.
No, that question is that if you have a cold, they're asking to do a full lung function test. Why that is being...
No, I don't.
It's
I mean,
after post-COVID?
I think that relevance is different. It's got nothing to
The
do
post-COVID or...
No, it's got it's got nothing to do with COVID. I mean, first of all, there is this knee-jerk tendency to overdiagnose and overtest. That is there. That is there for everything, So you err on the side of excess, but it has some relevance in the urban population, in the city population, especially when people and young children come up with recurrent coughs and colds in this winter time with high atmospheric pollution. Because that helps you to differentiate the early onset childhood asthmas. But you shouldn't overdo it. It doesn't mean that you sneeze 3 times, you go and have a lung
So I'm just going to
function
add to that, it's not about doing something, it's also about knowing when not to do something.
Yes, your sense of discretion.
Yeah, so as I was saying, how do you define a good surgeon? And we have a great surgeon sitting with us. How do you define a good surgeon? A good surgeon is someone who knows when not to operate. Similarly, a good lab will also tell you when to do a test, but also when not to do a test. So I think it's not about just telling you that, come and do these many number of tests for this much cost. I think that's not what our approach is. Our approach is to make sure that you get the relevant test at the relevant time, but also to tell you when not to do a test. Simple example, women are very prone to urinary tract infections, right? Very common in women. And you will do a urine routine test and it will show you pus cells. And invariably you will take that report and you will start on antibiotics. And after 2 days of taking an antibiotic, the treatment has not worked, and you will go back to the doctor. Doctor will say, why don't you go and get a urine culture done? People can relate to this. Now, what happens is that when you've already taken antibiotics for 2 days, it may not have killed the bacteria, but it will prevent the bacteria from growing when we want to culture it. So a good lab will ask you that history and check if you are already on antibiotics. They will tell you, stop the antibiotics, wait for 72 hours, and then do a urine culture. Because doing a urine culture while you are on antibiotics will give you a falsely negative result. You will get a negative culture report, even though you may be suffering from an infection. But if you were to wait for 3 days, then do a urine culture, you will be able to get the right result. So it's also about knowing when to do, but when not to do as well.
You see, on the subject of tests, there is one very common scenario which is almost like a social tragedy in India today. Because we believe that officially 30% of Indians are diabetic. I mean, probably the Home Ministry a few years from now won't give you an Aadhaar card if you are not a diabetic, right? But the question is, look, this is very common and most of us needs to be aware of it, that diabetes is not lethal because of the level of sugar. Diabetes is lethal because of the organ damage on the eyes, the heart, the kidneys, mainly. And you can have nerves, brains, what have you. So it is so common in society today that people go and see their doctor and ad nauseum they are having blood sugars done and HbA1c done, fair enough. But many of them, even especially when they are on the wrong side of 45 or wrong side of 50, so few of them have ever had a cardiac checkup, has ever had a renal ultrasound scan done, or ever had an eye test. So these are some of the things, because you see, in this madness of chasing specialists, what is happening is, I feel it very, very sincerely and seriously, that we are losing the cover of common sense. And because the cover of common sense is very often missing from medicine today, that very often we cannot see the wood for the trees. You know, people will come to you with a file so thick about last 15 years diabetic tests, but not one echocardiogram is seen over there, and they present it, and it's not their fault. Somebody who's seen a doctor regularly for 12 years, 10 years, 15 years, shouldn't come to you with a completely clapped out condition. That's a travesty of justice. So this is something all of us, we are, I think, we all need to have these little bits of information in our head, because diabetes being what it is today, we still don't know why it is so rampant. We haven't got the foggiest clue. But diabetes being what it is, control your sugars and look after the end organ damage. That is extremely important, because otherwise, needlessly, many of these things gets detected when, we are really at the fag end of the rope, so as to say.
So I think one of our objectives as an organization is also to create the right kind of messaging and communication and education. So that's what we're trying to do. It's not about just telling you to do the test, but also telling you why to do the test, when to do the test, when not to do the test, how frequently it should be done. So when we're telling you about diabetes, we'll also tell you that once a year, get a retina examination done, get a foot examination done, even though we don't do that, but it's part of educating the patient completely. So I think patient education is an equal part of our endeavor to make sure that we democratize the way tests are being prescribed, being chosen, and actually being done.
And we end up by saying this, this labs do have companies who provide you the equipments and all that. This one of those labs is companies called Orthoclinical Diagnostics. I was there in one of their discussion presentations, and they started saying that because every test is a life. It starts with those dots, because every test is actually, via test you actually diagnose diseases and actually give life. So that's the value of diagnostic tests. I think we can end by thanking both of you, Sanjay and Kunalda, and of course Sucheta, for giving us this opportunity. Thank you all very much.
Thank you.
Thank you.
Can I ask one question, please? Excuse me here.
Yes, please.
Is autoimmune disease reversible?
You see, basically autoimmunity, there is maybe, some diabetics, there is a version of diabetes which is autoimmune. Let's talk. So the question basically is that autoimmunity, you cannot, because it happens in the system, as Sanjay said, say regarding Hashimoto's thyroiditis, there is a version of diabetes which is autoimmune. That is pretty common, we are picking up now with the prevalence of echocardiogram. Young women who are getting pregnant, about 12 to 15% of them are presenting with postpartum cardiac disorder, post-delivery. Suddenly, out of the blue, hale and hearty, maybe in their young 20s, they look as if their heart has come under a bus. And why is that caused? Because the mother has developed autoimmunity against the child antibodies, and the heart, they have gone and got stuck to the heart muscle. There's nothing you can do about it. Treatment basically is modulation of immunity. There are some medicines which are called immunity modulators, and most of them would probably improve on wait and watch. But things like thyroiditis, you will have thyroid hormone deficiency, which has to be corrected. But many of them can be well controlled today. Some of them, are real pains, and especially when autoimmune diseases affect your connective tissue, bones and joints. That is a bit of a sticky wicket to play on. But overall, the results of treatment, I think, with good diagnosis, I think...
So I think I can answer that a little as well, that if you know the underlying trigger, and if the triggers factor, so there are many conditions, autoimmunity being one of them, where you identify a trigger, and if you are able to remove that trigger, if you're able to control the trigger, you're able to control the condition. So it's also about knowing the trigger as well. So I think cure and control, these are two different words. Most conditions can be controlled. Unfortunately, not too many can be cured, really. So, but if you can identify the underlying trigger of autoimmunity, many times there is an underlying trigger. If you eliminate the trigger, you eliminate the condition completely.
So we do require an allergy test for that, mostly, and we don't know where to...
Allergy is one example where if you underlying, if
Allergy tests are, the way we do it now, they are generally useless.
there is a blood test now for allergy, you can do an entire allergy panel through that.
All these sniffing of stuff and all that.
Good evening all. Thank you, Dr. Arora and Dr. Sarkar. What a wonderful session this was. You shared so much valuable information, dismissed some myths, and cleared our doubts. Your advice on how best to deal with our worries has been very fortifying. Our sincere thanks to Dr. Arora for taking time out to come and speak to our members. Thank you, Dr. Sarkar. You're always a pleasure to listen to. Yours has been a strong voice that has given us direction and hope over the years. Our warmest thanks to our executive committee member and dearest friend Rupali, Dr. Rupali Basu, for moderating the session so skillfully, ensuring that as many issues could be addressed as possible. A big thank you to all our guests and members for joining us. I'm sure we all found the interaction extremely informative. We would also like to thank Taj Bengal management and staff for the arrangements today. Thank you, T2 from The Telegraph and Sanmark for your continued coverage of our events. May I please request Mrs. Parul Swaroop and Mrs. Preeti Kapoor to join us on stage to present a token of appreciation to our speakers.